So my name is Dr. Sandesh. I am from batch 7th of ASCI. Sir, I have been a public health consultant for the last 7 years. So as the platform was open for the question, I just wanted to ask. So I mostly work at the national and state level also, but there are several applications at the PHC level. More or less below PHC level we have sub-centers or health and wellness centers, where there are 17 applications which are pushed towards ASHAs and ANMs for filling the data. And as we know, so most of them are very with a minimal education, who are either 7th, 10th or 8th passed from the community. So there are two challenges, sir. I just wanted to understand how they can be solved. One is the data which is being entered is entered for the sake of entry. For example, because they have a CPHC application where, as sir told Guru sir, that there are 5 things which they have to capture: diabetes, hypertension, 3 types of cancers. But the data which is being entered is not being accumulated at the district level, and similarly it happens at the state level. So how this should be answered, because there are many applications for them, and this is completely pushed towards them. And the second question is, sir, this is for the integration of public and private hospitals. So most of the high-risk pregnancy cases at the village level or community level are tracked till the 3rd trimester. But at the end of the 3rd trimester, it completely depends upon the trust of the doctor at that PHC, or at Tier 2 and Tier 3 villages, there is a famous doctor that they will go to them only. So how that data can be captured at the private hospital so that it can be again transferred to government hospitals, so that the post-delivery care can also be given to the patient. Thank you.
Guru, you want to take that?
One thing I want to tell you is that the quality of data now coming are far better than what it was 5 years back. And quality of data is being used to analyze lots of things. Please be under no illusion that government does not know what's happening. Actually, government knows a lot of things. It doesn't come out. It knows exactly where there will be an outbreak, because it has got those data. Please remember this whole thing about, and it started years ago from Odisha when they did the IDSP stuff and all those things. So please remember that data is there, good quality data is there, and data is coming. You'll always have problems with data. You know, end of the day, if I'm allowed to write who is the chairman of Tata Group, fill up the data, I will put my name. Why should I put Child Chandrasekhar's name? So I will put my name. So that kind of problems will be there. But please believe me, data's quality is improved tremendously in last 10, 12, 15 years time. One. Second is that please treat private and public separately. You will never get them to work together simply because that private guy is driven by ROC, ROE. He is driven by how much money he makes. He is driven by what comes in the envelope. PHCs are also terrible. That's a different story. But then everything has to be looked at differently. Private healthcare caters to 10, 12, 14, 17% of the population. Focus on public healthcare, which caters to 65, 70, 75% of them separately. Things will be much better.
I would like to disagree with him. I think we cannot give up so easily. Say that private healthcare cannot be fixed. That is the job of the government, to fix whatever it has to be fixed. Now, one way to fix it, the thing about our book is that we have not stopped at problems, we want to offer solutions. So one way to fix it is, make this electronic health record, just like Aadhaar. They have it now, they have the ABBA ID and all those kind of things. Make it mandatory. And one of the thoughts I had was, you have electronic record of every healthcare interaction. The patient should own that record, in the sense that the patient should have access to that record on demand from the cloud. And link every dispensed medicine batch number to that record, so that he cannot buy a medicine without the electronic health record. And the medicine he buys is automatically linked because those comes with batch numbers. So if you universalize the electronic system, make it owned by the patient and make it available for audits. And artificial intelligence can do a lot of the audits. It can pick errors in prescriptions, it can pick up unethical prescriptions, it can pick up malpractices. Even if you give it a million or 10 million prescriptions, it can do it in seconds. So with this combination, it is possible to bring about change. I am not saying that this change will happen fast, and I'm not saying this change can happen without the government. In fact, I'm saying the government, this is what the government should do. We have the technology, we have smartphones on which apps can run. Mandate tomorrow that every prescription should either be on a smartphone app, or if it is on paper, it should have a unique ID that you can send an SMS to a central number, it returns an ID, which you can write on that prescription, and that, because it is now captured electronically, when he goes to a pharmacist to give that thing, that number is captured by the pharmacist, correlated with the number centrally, so that the entire healthcare process, there is an electronic record. So if the doctor does something bad, like prescribing too many medicines or prescribing the wrong medicine or fakery, whatever it happens, or even if the medicine is contaminated or there is a batch problem, this will all be picked up very fast. This technology is possible today. It may not be possible in some tribal regions for some reason, but with paper, with paper as a backup, it is possible to do this today. So I say that this is solvable pretty quickly, 6 months.
Just to add to the data thing, as Guru said, government is now very little more proactive. So we had this opportunity to interact with the government, and we had this meeting with the health minister and secretary, and just before our presentation, we were doing some work for them. The director of health had actually put across a sort of an epidemic data, and we were very sort of amused by one data. It was actually told COVID. So what's the numbers? So one of the reasons they said was, there is no media reporting of COVID in this 24 December, but they said, no, we are very proactive. We know that this is a time when the data is actually going to, there may be a potential this, but we are ready actually. And interestingly, it also is the political thing. I was very surprised when the health minister understands better numbers. Nowadays, he was asking that what generally our tendency is as economists or something, we put numbers, we think that, but they don't understand. And that was what, when we used to work in the government, we used to always put paragraph for explanation. He said, no, you explain the numbers, I can actually understand. So that political awareness is also very important. And I'll give you one more example. I think from 2007, Arabishri has been there. And I think ASCI has been trying to do an evaluation. We wanted to know whether the out-of-pocket expenditure has come down. Even though we got finance department clearance, health department didn't give us the clearance. They thought, if something comes out, something will be wrong. Things changed. I think 2 years back, we were called to the Arabishri. They said, we are going to give you the entire data set. We'll give you the whatever Arabishri data, but you want us to do a small exercise because we want to add new packages. There's a lot of demand which has come from both government and private, whether some of these packages should be, so many of our colleagues actually visited some of the hospitals. We took data from NIMS, Gandhi Hospital, some of the private hospitals. Then we were all sitting, use that data, then come out with a sort of solution, and then actually there was a vetting which was going on, and each time they said, what does the data say? So using of data, which is now becoming a good thing, is actually helping in decision making. And I'm seeing in many states which they are doing. I think they're partnering with academic institutions, with private sector also. I think there's a lot of, I still agree that there's a lot of opportunity where collaborations can happen.
I just want to react to him. See, Baiju, before it became big, went to schools to figure out what is the standard of teaching and all that. Everybody gave the information thinking that, something is going to happen. After that, Baiju came back and sold a 2 lakh rupees package to every student, make them take loans, and destroyed a generation of people, giving close to around 3,000 crore rupees worth of nonsense to people. Okay. Similarly, more you go into checking out whether the prescription is right, the medicine is right, he's going to get into a bigger problem, a bigger mess. At this point of time, Arogasti does a fairly decent job about how the treatment protocols are taken care of. Fairly good. And Ayushman Bharat will start doing it. CGHS has been doing it for very many years. ESI has been doing it for very many years. So things will start stabilizing because data today has got a value and data is coming out, good data is coming out. If you do an ROBC, the quality of data is good. I would ask a question to sir. With all that which is there in technology in US, what is the level of medical errors, sir, there?
Very high. Very high. The problem is we take certain metrics into consideration and then measure a physician. For example, correct diagnosis is taken for granted. It is never factored in any of the metrics. It is a domain expert who has to say that you're completely on the wrong track. Instead, you are saying whether you gave an antibiotic in 4 hours of time, whether HbA1c was brought down. Now, in the enthusiasm to bring down the HbA1c, you killed more patients with hypoglycemia. A sane physician will think, is this elderly person with cognitive decline, will he tolerate hypoglycemia? In that patient, I will have a little lenient control. Will this patient tolerate an aggressive BP control? No, he won't. He will fall and fracture. So you can't use numbers on every single person. Similarly, for example, the commonest cause of neck injury, trauma, spinal trauma, is an uncovered well in Tamil Nadu. It may be a motor traffic accident in some other district. The commonest cause of pediatric deaths in rural Maharashtra was scorpion sting. There the treatment is completely locally developed. So medicine, instead of, that's where I disagree with what you were saying. It is not like a blue collar worker. We practice as an art. What is local to that particular person, whether he will take this drug, what are the barriers, that is local. What is the food that he eats? Can you modify something? So that is never, the question of diagnosis is taken for granted. The bedside manners is taken for granted. We believe that there is no drug interaction. When you have 4 different conditions, when you aggressively treat heart failure, treating for heart failure worsens. If you look at a matrix of heart failure therapy, this drug is prescribed, creatinine starts rising. We don't think that over-treating one disease can result in a worsening of another disease. So it's quite a complex disease. Human as a whole, you should think that, again I come back to this, you need a comprehensive internal medicine or a physician to lead the whole system rather than individual specialists who just glorify certain procedures and take credit for that. I think they have completely missed the bus.
I have one more small observation. ChatGPT has come, DeepSeek has come and all that. So you are going to have more fun. Doctors are going to have more fun looking at alternative viewpoints. He'll say, I went to ChatGPT and he said that I have this problem. And I will go to him and say, what are you prescribing? This guy says I have to prescribe. So you'll have more fun now. And I'm waiting for that to happen for next 1.5 years time, when there will be a lot of fun in using technology for what it